this afternoon, and thank you for the panelists for joining us today. Today, we'll try to understand and identify what contributes to claim mistakes early in the process, which is critical to decrease the errors and improve collections. Our topic of discussion today is decoding patient billing and claim life cycles. Today, we have a very esteemed panel with us, and to moderate the discussion, we have Dr. Ashwath, who will talk throughout the webinar and will be arranging through the important points about the topics. We here have four esteemed panelists and speakers. Dr. Saumitra Bharadwaj has over 2 decades of diverse experience in the Indian healthcare industry. He has had the privilege of watching and actively participating in the phenomenal growth and transformation of the sector. During his career, he has worked with some of the leading Indian companies like Dabur, Apollo Hospitals, Fortis Hospitals, and Max Hospitals. In these companies, he has taken up different leadership roles across different health related industries like health.com, health insurance linked TPA work, medical administration, hospital operations, marketing, retail pharmacy, telemedicine, and corporate strategy. Secondly, we have Saurabh Gupta. He is a seasoned healthcare leader with global exposure to hospital P&L operations, organizations redesign, business transformation, project management, and consulting assignments. He's currently working as a vice president operation at the 1,000-bedded Medanta Lucknow as its business head. In his career spanning over 18 years, he has been associated with Fortis Healthcare as head of strategy and operations excellence with McKinsey, GE and PwC as healthcare consultant, and have executed projects in over 10 international geographies with some leading hospitals. Thirdly, we have Colonel Bipin Pathak. He was commissioned at the 2nd Command in June 84 and subsequently converted to the Intelligence Corps in 1993. He has served in various CI grade and have been posted to various posts from Officer Commanding Intelligence Detachments, Staff Officer Intelligence at Army and Corps Headquarters, Field Security Detachments, Registrar of Sanic School and Joint Director handling Accounts and Asset Management of ECHS. He's an expert in the areas of security, strategic planning, vigilance, and threat assessment and material, and personal management, including general administration. Last but not the least, we have Dr. Arpit Bhatnagar. He is currently working as a head for medical services and network operations in one of the leading TPAs. He has a diverse experience of working in the healthcare industry and is skilled in the hospital management and business operations. He has a wide exposure of working with organizations like Fortis Healthcare, Apollo Hospitals, 1MG, and more. Thank you, everybody. And Dr. Ashwath, you can take it forward from here.
Thank you, Vibha, for that quick and wonderful introduction. Ladies and gentlemen, welcome to this series of webinars. We are trying to focus on hospital and healthcare management related topics. And today I am lucky to be, connected with some of the esteemed panelists over here. Welcome, gentlemen. And,
Thank you.
Just to get the ball rolling, initial 5 minutes, speaker will be given 5 minutes, and we look at the whole problem of claims processing and accounts receivables from a 40,000 feet bird's eye perspective. And I would like to invite our first speaker, Colonel Bipin Pathak, sir, to open the discussion and get the ball rolling, sir. Sir, the stage is yours.
Well, thank you for the invite. And it's my pleasure to be associated in discussion with MetahOS and the esteemed panelists. As the time is too short, I'm not going to cover into the background of ECHS because I'll be limiting my reflections on ex-serviceman contributory health scheme plus online billing, because that is more important to the panelists that deals with cash flow, etc. I'll be limiting my talk to online billing, and maybe inadvertently my comments may not suit either the government or the hospitals, but then I'm extremely sorry for it. It's an open debate. Anyway, I'll try to avoid being crash to any of the organization, be it mine, be it others. To begin with, ECHS has been dealing with hospitals for a very long time. It has been instituted for looking after the healthcare of veterans and supported by the impaneled hospitals. And I think it has been functional since since 95. And today we have around 27 regional centers, 427 polyclinics, and over 2,700 impaneled hospitals to look after our veterans. Now that amounts, you can see the inflow. If we have 2,700, what would be the budgetary allocation? So every year there has been an enhanced budgetary allocation for the healthcare in the central budget of the MOD, but still the problem of payment to the hospital persists. They are also right. If they do not get the funds in time, they are stuck up because they require, for maintaining their own infrastructure, payment of staff, procurement of equipment, etc. And if we delay, they are at a loss, as ECHS has no intention to delay. That is the reason why we contracted bill processing agency, which is under the Ministry of Corporate, to hasten the billing process so that everyone is basically happy and no one has any points to crib. Earlier we had manual billing, so there were a lot of hassles. So from manual we converted to online. And now with online billing also, most of the hospitals are they have been cribbing about the backlog. And in certain hospitals, the backlog is to the tune of 100 crores, 200 crores, 300 crores. There has to be a reason for it. And reason, both sides have to be blamed. As a neutral person, I too would take the blame and blame the hospitals too, because of that most important thing which has been written in your ad of MetahOS, need more information. Now, need more information is raised when there are certain observations by bill processing agencies or by the people manning online sections in respective regional centers. Certain hospitals, they ensure that the observations or the queries are immediately answered so that the process does not stall. But at times, there have been many hospitals where the backlog has been for six months, one year. People forgot about it to answer. And ultimately, when they carried out an internal audit, they found. And initially, they blamed the RC and all. But whenever the staff came over, they were convinced it is not our fault. The fault lies at your end. And there may be various reasons. One of the reasons is the person manning online, they keep on changing. Maybe the staff is inadequate to cater for all these things. And certainly you require people who are efficient, who are willing to learn, who are dedicated, and who do not jump jobs very frequently. Because the person who learns, he's quick to point out where the mistakes have been committed. And those things are rectified and everyone is in a happy situation. But later on, I can come out what the major points of need for more information are, because of the 5-minute shortage. I won't be able to elaborate that. Now, secondly, you have the BPA. BPA is manned by experienced doctors who have got a lot of experience. So they are capable of finding out the mistakes. And thirdly, some of the hospitals, they don't follow the moral code. They indulge in unethical practices. Like for an example, they bill for both the knees, and whereas they attach the documents or the X-ray report of one knees, both the knees. But those people, we've got orthopedics sitting there. They are all civilians. They have nothing to do with the army. They have nothing to do with me, nothing to do with the hospitals. They're neutral. So they are the guys who raise the observation. Now, how do you answer back? So they have to be certain things. Then secondly, the interaction between the respective RC and the hospital is very minimal. The hospitals are just limited to the person who goes and deposits the file, the hard copy, that is all. You require people who are manning them at the top so that they come and interact. They find out what is the reason for the delay. And if it is at our end, you should not hesitate in pointing out or writing letters to people concerned. Absolutely. Because we are also human. You are also human. Your staff is human. If we have committed a mistake, we should be aware about it. Earlier, what used to happen, the hospitals used to deposit their files, hard copy, and our chaps used to be just sitting around with the hard copy for days. But later on, we ensured that first come, first serve, whoever comes and deposits, they'll be uploaded immediately, or it's already uploaded. They will check the documents for verification and forward it with their comments to the BPA so that the time delay is reduced. And I only hope it still continues. So this is the things which we face. And later on, I'll come over, which the points the hospitals can raise with concerned people, because you have your member of parliament, you have Rajya Sabha. Till the time they do not take up the case of enhancing the financial powers of Director RC, which is limited
100%.
up to 4 lakhs, things will be
Yeah.
delayed.
Yeah, absolutely. And
So they have to take up the case. And for us, it will be a big problem, because I've told you, we've got functional control under the MOD, we have got executive control under the Adjutant General, we have another control in respective commands.
Agreed.
So you will never find an answer. It is up to you to take up the case to enhance, because things have become expensive. 4 lakhs is nothing for a treatment.
True. More of systemic changes are also required. And
So hospitals
you
have
have
to think
given
about
us.
it and take up the case. So here, I'll stop my reflections.
Thank you. Thank you, Colonel Saab. I mean, you gave a very wonderful, walkthrough of both the sides of the coin, right? And we do understand, there are a lot of staff action, a lot of training related issues, a lot of systemic backlogs, a lot of policy changes which are required at the top end. So it's both the ends which need to come and meet somewhere in the middle. So that brings us to the next our next panelist, Dr. Bharadwaj. Why don't you walk us through the kind of the processes or the patient journey and most of the common mistakes throughout the journey? Sorry, I think it was Saurabh Gupta. Mr. Gupta, you can proceed, please.
Okay. So first of all, thank you very much. I'm 16 Labs, and I'm actually quite fortunate to sit among such esteemed panelists. I wish to be enlightened after the end of this session. Okay, I would actually like to step back a bit. So there are 3 primary stakeholders when we talk about this entire billing and claim settlement process. You have the beneficiary, who is the patient or the customer. The second would be the payer. Payer could be the TPA, ultimately the insurance company, ECHS, CGHS. There are a host of entities who can be the payer. The third would be providers. Unfortunately, none out of the 3 is happy in the case. So providers have their own issues. They say that it's a tedious process. We don't get reconciled bills. There are a lot of issues. We have aging. We have then ultimately bad debts. It's already discounted. We have requirement for working capital. When it comes to payers, they have their own set of issues, and of course, we will hear more. But I want to focus more on the providers, because that's what I represent, and the patient, because ultimately it's the patient for which the entire ecosystem has been built, and it is the patient for which the entire healthcare system stands. Now, unfortunately, this patient thinks that he is very empowered, because when the insurance policies, and I understand that we have a host of payers, but an insurance policy is sold. They make him feel like, he has literally one half of the world. So it's pure cashless. You will get everything in a hospital. You just walk in, which is not true. When he actually lands in the hospital, he realized that there are so many formalities. There are paperwork. There is literally banging his head from, pillar to post. So the realities are very different. Now, as providers, there are few things which we need to do. Of course, there are responsibility of the payers. So as providers, there are 3 primary things I would like to focus, because the time is short, and we have Dr. Saumitra. He will talk more about the processes, but the focus should be on communication, the process changes, and the use of IT and analytics, which is very, very important nowadays. So first of all, communication. Your revenue cycle actually starts from the time patient enters the hospital, or even before that. Now, there are instances, we have a very sound OCC, we call it Operational Control Center at Medanta, which is the hub of the entire patient activity. So the moment patient calls for an appointment, we actually ask, sir, whether do you have a insurance policy or any benefits, because what actually happens is, and half of the time they don't carry the document, but we try to capture all the document in the first instance itself. Because if the patient can carry some of the documents, and now Aadhaar is mandatory for all the new registrations, so Aadhaar is there, but we also ask whether patient can carry other documentation. So our system captures all those documentation. It goes in the system, so that the documentation process up to some extent is taken care of. And communication is very important. When the patient is counseled, and we might not be the best, but when the patient is counseled, he is clearly told that based on your TPA, your insurance provider or the payer, there are possible deductions and you will have to pay upfront. Even then, there are people who deny, no, I have a cashless policy, I will get through. So communication is the key. Then when the estimates are given, patient gets admitted, everything is sent, there are chances when we actually miss it, but the point is not to hide any pre-existing disease, because this is a major contention. There are chances when it is being missed and the entire claim gets rejected. So this is again, a communication is, we as provider must tell the patient that no pre-existing disease should be missed out, and anything and everything has to be written on the forms, or it has to be uploaded on the website. It's also the patient's responsibility not to hide anything at the time of admission. Okay. Now the second thing is process changes. As I am telling that even nobody is perfect, but what happens is when we try to help the patient whenever he comes, not to actually get this patient or customer run around the hospital to the doctor, to the TPA desk. We try to get someone, but there are chances when you have 600, 700 patients coming in OPD on a single day. It's the patient who actually goes and carries the paper. If there is a query also, it is actually hospital's responsibility to go to the doctor and ask the doctor to solve that query. And time is of essence, as Colonel Pathak has already said, that sometimes just because of queries, the process gets elongated. The other thing is use of analytics, as I am telling you. The use of analytics, if I know, and this is the thing, that if I know that based on particular algorithms, and I have seen some of the new startups which have come, like Claim Therapist and all, they have developed algorithms which can actually tell you 80 to 90% accurate that these will be the deductions. If you can develop some algorithms or deductions, now I know that CGHS doesn't pay for a new thermometer, I will still bill it. My HIE system will still bill it, and it will come as a discount or deduction. Or sometimes what happens is, we have an HIA system which has a problem, but sometimes the discounts do not show up. All the TPAs and all these payers have a discounted rate. Now the system picks up, when I actually run a report, system picks up the outstanding as per cash, whereas my receivables are much lower. Now what happens is the receivables which I see are actually not the correct receivables, because the receivables should be less. The number
there is
less
no tally over there.
Yeah. Now, if the HIE systems are rows, I'll get the exact number. The problem is, so analytics is a big thing. Then, if we can scan and upload through the same software, it actually saves a lot of manpower, which is not the case.
Agreed.
Also, the day from the way which the outstanding gets calculated. Is it the day of the discharge of the patient? Is it the day of the dispatch of the bill? Or is it the day when the bill is actually received by the TPA or the payer? So these are some of the things to be answered. And again, time is short. But, if analytics can help, that would be great. And if I have checklist, that these are short deductibles, that will be of great help.
Correct. Very well put, sir. In fact, you highlighted two key aspects, like there are multiple parties involved, the payer, the provider, and the third party processor, and in between so many people involved, and the patient, of course, and also the communication aspects, the IT infrastructure, the software capabilities. Dr. Saumitra Bharadwaj, you've been in the industry for almost 2 decades now, and the flow of the finances and the coordination between departments, the front office, the registration, the counselors, the doctors, the processors. Could you please elaborate a little bit on that aspect? Sir, I think you're on mute.
Am I audible? Yeah. Good to be among the people from the fraternity and from the industry. And I was just saying that, yes, I've been around for almost 22 years doing this work. I have seen a sea change in the way things have shaped up. Colonel Bipin and Saurabh have given their insights on the issue. There are many things to talk about, but I would like to base myself on a few important aspects. As Saurabh said, there are 3 stakeholders: the patient, the hospital, and the payer. So let's just talk about hospital. Within the hospital also there are different stakeholders, and each of them have their own impact, positive and negative, on the outcome of accounts receivable. You have the front desk, which does the authorization. You have the billing people, you have the clinical teams, and then it goes to the claims people, and then finally accounts receivable. But the real problem lies in the systems which have been created right now. The end of the assembly line is accounts receivable department, and they should be the primary assessors of the whole system and the whole process. But what we see is this become back end of the back end. Fine. And these so-called silos which have been built contribute to the problem from the hospital's end. Billing people don't do collections. So it's very important that the billing people be sensitized by the collection people. And I make it a point that collections team at least meets once in 2 months with the billing team to let them know about their heroics, which they think is right, but it's actually not considered right at the end of the line. This has a big impact because many times they are justified in their logic. Ye kaise ho sakta hai, ye nahi ho sakta hai. But we say at the end of the day there is a fixed scheme of things on which claims are being passed, and you have to abide to that. That's one. Other things which Saurabh pointed out, and it's very important, that the incapability of the software to address the normal requirements, forget the nuances. You see, this cost of treatment as per the scheme and cost of this treatment which comes in the cash basis assessment sometimes are not clearly defined, and it creates havoc. So much so, sometimes quality requirements make it mandatory to use certain amount of consumables or certain inputs and devices which add up to the cost, but they are not reimbursable. So how do you handle that in the scheme of things? The billing guy will bill it because save his job. The finance guys and the cost accountants want it recorded on paper, but it at the end of the day creates a bill which is not possible. You see, now always what is important, as you said, what is the cycle? Now, if I get money within 15 days and I get money in 90 days, there is 6 times difference. But the people today don't realize this, that if you have a cleaner bill, you get money faster, and you can recycle the bill thrice, 4 times the money. So the concept of clean billing, great claims, and quick passing is now something which is now taking precedence. over earlier earlier way of fractioned approach to creation of bills. Now, while we sort of thrive on all these learnings, there is a complete 180 degrees turnaround with the new policies. Now, what you see is happening today in the market, that the claim team and the billing team, all of them, they awaken at discharge. That is the time their work really comes into being. But those days are gone. Now the authorization happens at discharge. So everything should have been finished before that. Okay. Now all the learnings have to be unlearned. All the so-called laziness of the system has to be eradicated. Now you have to close a bill, but your so-called the bill for implants, the bill for consumables are not there. Now the whole country is not ready to handle all these things. Okay, while certain thinkers have decided on confirmation of payout at discharge. Now the hospitals are not ready for that kind of system where all the systems can close at discharge. So we have 2, 3, 4 days of pending bills. Now aging. Now aging as a science, as Saurabh said, he gave us 5, 6 variations. I got confused. But the fact is that all of them are true. You know, so it is at discharge, it is at claim, is it as sending, is it as receiving? In my opinion, the country should talk about when the claims are received by the payer as a very good, but wo kahin system mein catch nahi hota. It is never recorded. Aging has got so many issues, and that's why I'm saying account receivable as a function in the hospital is something which will really affect your stress levels, your work, and your longevity in the organization. Today, you will not come across any account receivable team member who has done more than 2, 3 years in an organization, when actually he is the real engine and the reservoir of knowledge on how to really make the finances work. So with that, I'll end my input, and I would ask you to take it forward.
Thank you, Doctor. Some really important points you raised, and one of the key highlights is like most of the processes currently are people-centric, staff-centric. It is that one person in the billing or one person in the front office who kind of knows everything, and if he or she takes 1 day leave, it kind of the whole system gets messed up. So, Dr. Arpit, I'll bring you in. Last but not the least, but of course, to get a perspective both from the operations side of it as well as the clinical side of it, what do you think the problems are? If you could just walk us through the larger bird's eye view optics.
Thanks, Dr. Ashwit, for having me here. It's extremely great to be a part of this fantastic panel here. So taking forward from where Dr. Saumitra left, so as we rightly said, he was talking about the turnaround time. So by the time the hospital gets the bill, gets the complete file, and they send it across, it's already 7 to 10 days old. So so that's not where the exact problem is. So the one step is when the hospital is sending the documents to the DPA, either it's through a normal courier or it's uploaded online. Because of this COVID pandemic, the insurers have allowed us to process the claim based on online claims. But having said this, the hard copy is still mandatory. So the problem that TPA that faces is hospital shares the POD number. POD is like point of dispatch or a courier tracking number, which gets difficult for the TPA to track. So that's one of the problems. So by the time the TPA or the insurer receives those files, it's already 15 to 20 days old. And it's also very important to share the right documents. So once a particular document is received, there's an inward team at the TPA which inverts the document. Once it is inverted, it goes to the claims team where the claims is actually processed. Ideally, the time should be somewhere 2 to 3 days once the document is inverted for the claims team to process it. But once claim team actually reviews it, they realize the document which was provided by the hospital, there are a lot of things which are not there, which should be there. So that's where in the claims team, they raise a shortfall. We call it a shortfall. And they're very basic shortfall that we expect the hospitals to share. I mean, it's a very basic thing, as good as a final bill, as a discharge summary, okay? Where an implant is used, an implant invoice, okay? So these things are there, which actually further delay the process of payment to the hospitals. And I completely understand what I think what Saurabh told and what Dr. Saumitra told, and I think Colonel Pathak told, that I'm not denying the fact that the hospitals are at the receiving end, because they are the one who are providing good level service to the patients and doing whatever they can. Having worked in hospitals previously, I can completely correlate. So, but having said this, on the TPA side, things are not at all easy for the TPA, since the time the insurance company has denied TPA to pay the amount, the payment is done by the insurers. So once a particular claim is passed, then it goes to the insurer. Our team of finance executive, they upload it for payment. Then there are different challenges, like there's some error in the insurer portal, the account number which is there with us and the insurer is different for that particular hospital. Another challenge I would like to highlight here is recently hospitals have different accounts for different TPAs or different insurers. So I don't want to name the insurance companies here, but they have certain protocols and they just want to be very, very stringent with that. So it gets difficult for us to get it to. I'm not denying the fact that TPA are processing everything absolutely correctly. Yeah, there are certain errors which happens in the system, which happens at the processing end. But having said this, if there's proper documentation being shared by the hospital at the right time, the turnaround time is somewhat reduced. This is one. And there are long waiting time for the bills. We call it bills. The claim document which we receive in the TPA, we call it bills. The long waiting time for those. So we have a team of around 5-7 people who follow with different hospitals for the bills. And then also we don't get a proper response. Okay. Then it's like TPA doesn't have anywhere to go, because especially because of the COVID, a lot of insurance company has said, okay, my turnaround time is 7 days. Another insurance company is saying my turnaround time is 15 days. So the TPA don't receive the bills because then they can't process. Shortfalls not being responded by the hospital in time. So these are some of the challenges that I see being a part of the TPA industry are very much there. And I think that the right way is, of course, technology. Like online upload of the claim document. Then also there are a lot of training issues which face from the hospital, like the document is not being uploaded in the right, say, pre-auth number or in the right particular claim. So wrong claim linked to wrong pre-auth. So all these issues are there. So if I think that part is being taken care of, I think the claim processing will be easy, and effective communication from hospitals is very important, because the problem that we face being a part of TPA is, even though we are calling hospital that there's a particular shortfall, and all these shortfalls are reported online to them, they get all the mails and all, and we don't get that proper response. So that's the main problem that the TPAs are facing. I'm not denying the fact that yes, hospitals are not able to maintain the cash flows, especially because of COVID. I can completely correlate. And being the financial year end, I can, again, this is the right time for this particular discussion, because the hospital wants their cash flow to just go at the top. So that's wherein we all try to work together. But I think effective communication from hospital is very important. That's from
Absolutely.
Dr. Ashwin.
Absolutely. Communication is the core pillar, right? Because there are multiple parties involved, at least from a bird's eye view. We have the payment processors, we have the providers, we have the patients, and we have the all the thing which go on in between, right? So, of course, each insurance company has their own policy, their own payment cycles, anywhere between 7 days to 90 days. Complicating things, the number of steps involved in the claims. Each insurance company has set its own cycle or its own steps. That complicates things. Combined payments of multiple claims, like Dr. Bharadwaj says. And of course, during the tax season, like March and April, we are running from pillar to post to get things rolling. Reconciliation is a big problem. So the tax consultants, the finance guys. So one of the key points earlier discussed was that our systems on the billing side and our systems on the EMR side do not talk to each other. And there is a other third-party finance taxation software like QuickBooks or Tally or something like that, and that raises some other questions in between. So how do you guys think? I'll circle back, Colonel Pathak. So one of the key things is, how do we make sure that, yes, technology is a tool, but today we have too many tools. So how do we make sure that we bridge the gap and make it more efficient, the entire process?
Doc, like I won't be able to comment much from the technology side because I'm quite poor at it. As a layman, I'll talk about it, especially between us, between the BPA and the billing, RC and the hospitals.
Yep.
Like, firstly, what I suggest is the hospital should request for a capsule course every 3 months, capsule training for their staff at respective regional centers and BPA at a duration of 3 months or 6 months, whatever it is, where they can, learn what are the points which we generally focus on, why are they rejected, they can note it down and implement the same. This will be a ground training. I do not know about the software development or whatever it is that can be dovetailed into whatever you are going to make, because the software can also be made on training aspects, on especially where people go wrong, where the observations are raised. Whatever can be made technologically, I'm sure you guys are working on it. But as a layman, what I would suggest is for a faster and a transparent cash flow, so that everyone is happy. One is you have your capsule training every 3 months, because we have seen most of the online staff at the hospital keeps on changing because they go for a better jump somewhere else. So they have got to keep training. So it is better that 3 months you spend about 6 days. We started in Calcutta. Shantanu is a witness. We had started because the hospitals were facing problem. I had to personally request the hospitals where they're reluctant to send people to train. I do not know why, but some did send them. So we ensured these to come in the morning, sit with the boys and learn things, why the observations are raised, so that those faults are not repeated. And certainly those hospitals, they didn't repeat them again. The same thing can be done with BPA, which is located, I think, at Bangalore. They can take up a case where certain more qualified people can go do a capsule for about 4 to 6 days, come back, so that things do not stall anywhere. That is one thing. Secondly is
bottlenecks can be reduced.
We have to think of raising the financial powers of particular, like we have a regional director, his financial powers are up to 4 lakh rupees. Then you have a MD, their powers are between 8 to 15 up to. Then you have a joint secretary where the red tapeism starts. It is up to 40 lakhs. Then you have the secretary. These guys are all bureaucrats, 60, 40 and above. And the delay goes there. We had people who had 60 lakh bills of an individual pending for nearly 2 years. The hospital is not at fault. We are not at fault. Now, what can you tell the bureaucrats? Because that is how the government is functioning. But somebody should have. And ultimately, we had suggested to one of the hospitals whose bill was pending, we empathize with you. We have failed at our end. So there's a suggestion. Your bosses, I'm certainly aware of the political masters, they can raise it in the question hour. And when the question was raised in question hour, can you believe it, within 3 days, the bills which were pending for 2.5 years were cleared by the MOD's DESW section, because it was above 40 lakhs. Our MD doesn't have the sanction. So the faster bill is, if the regional director financial powers can be increased, so it is region based, they can, things can move faster. Or secondly, what we have suggested to the hospitals was, you break the bill, say a patient requires still about 3.5, then discharge him for a few days, then get him readmitted again, so that you can break the claim, because that is a faster. No doubt it's a wrong suggestion, but we did give, and people are pretty happy with it, because observations were certainly raised by BPA later on, how patient A has been again admitted after 6 days, and especially cancer patients and all this. But anyway, we always had that answer, so that was not.
It gets a little murky, and it gets a little.
It gets murkier, but then you see, everyone requires. We also want to finish it off. Thirdly is key budget allocation. I'm not talking from the private patient point of view, especially ours. Like initially the budget was around 2,000 to 3,000 crores. Now I think it's nearly 4,000, 5,000 crores. But that is what is allocated. But the government generally allocates between 3,000 to 4,000. So always every year you'll find about 8,000 to 8,000 crores pending. No,
Yeah.
you can't blame the
In
hospitals. They require that fund.
Absolutely.
They require
In fact,
it. So somebody has to be there. Now what happens is between the pending bills, between the claims, between observation, who suffers is the veterans. When they go to the hospital, they said, look, we are not getting money, so we are not going to give you the treatment. Right? They have been hospitals. They say, look, we have stopped. They give a notice that till the time our claims are not passed, we are not going to see the patients. Despite undertaking in the MOA, they will do it. Either the MOA should be very clear. In fact, in the MOA, it is clearly stated that BPA should clear their bills within a period of 10 days. If it is without any observation, so that the government gets a discount of 2%. Say if the bill is there for a certain amount, 2%, if it is cleared on the 9th day and the hospital gets the money on the 9th day, 2% is ours. Yep. But nowhere this is happening around. And the BPA has got its own excuse key, they are understaffed. It is not a fault of the hospital, they should insure. Because they are charging service charges also. Everyone is charging. So the hospitals also, what we had suggested was, everyone is responsible for non-payment to the hospitals, including hospital themselves. One is, we can't, he has already elaborated about the need for more information, certain point. There are a huge list about it. Second is, the higher ups in the hospitals interact with regional director. Now, what happens is no one takes a feedback of their online sections in the hospital. Whatever the gentleman tells them, ki, look, these are the amount of claims pending and abhi tak paisa nahi aaya. But the higher ups never bother to find out why the claims are pending. You give us a reason. We had a particular hospital of which Dr. Bharadwaj is now a representative. There had come Mr. Anupam Shukla and all others had come over with a huge list of pending claims. When we told them that these were the observations raised 6 months back, no one answered. So then they went talking to people out. So if you take a regular feedback, if you take a regular feedback from your staff every week on a Saturday or a Monday, ki what are pending, how many have you sent, how many observations have you received, what have you cleared, things will move faster. Yeah. Because ultimately the issue is, we also want that the hospital should get paid faster so that nothing is stuck up. Our services to veterans continue, because you cannot blame the hospital when they stop for the veterans, because they are also right, they require money. And we are also right because we have to see after the veterans. So somewhere a balance has to be struck. And we cannot plead to the hospital every time if they have thousands of crores pending, you look after our veterans. That will be very wrong on our part. We can only try to facilitate faster payments. Absolutely. But before that, the hospitals should also ensure. So these are the basic points where technically I've not spoken. I've just spoken as a layman, where we can infuse certain aspects where things can be faster. And especially if the higher administration in the hospitals, they start checking from the people why the claims are pending, what were the observations, and they rectify it. Matlab basically motivate their staff not to repeat such mistakes or to hide them under the table. And after 6 months, you take it out and then you start asking for a waiver for the time lapse.
Yeah.
So these are the things
yeah, I think you highlighted one of the key points, training aspects. So any of the panelists have any comments on the training aspects, both internally, but also, dealing with outside? Go ahead, Dr. Bharadwaj, sir.
I wanted to speak a couple of things on what Dr. Colonel Pathak said, but first the training aspect. See, the TPAs are actually one of the most, I call them the super specialists, who are mostly underrated today in the market. I think TPA guys, since we started in 2001 to 2021, they have really become extraordinary in their work, and they've come a long way, and they are truly the experts who are not being properly engaged and utilized. That is number one. Number two, it is not about training alone. It is about sitting with the payer, which happens with ECHS. They call us and they interact with us, and ECHS is in that way very much engaged because it is truly cashless on both sides. So people who are handling ECHS is not their money, right? There is only is their concern that things work out the best, and it shows. Fine. As far as veterans are concerned, we don't refuse. The very fact that they are veterans, they have to be extended all kinds of courtesies.
Yeah.
I ensure if any brigadier Saab or Colonel Saab comes, and he should be given a private room if it is empty, if we can extend it. But the problem is that the bureaucrats, they don't move till they get a kick in their butt. You know, that is the real challenge of the system. That's number thing. So I have a couple of suggestions, some magic suggestions to make things work. One is a simple interest clause. Put in, I'll talk to software later. Put an interest clause, suddenly everybody will become efficient. You know, government and private agencies for too long have been gallivanting very carefully and uncomfortably about they will pay when they feel like they can pay. So there is no urgency to pay. You know, now with all these new schemes which have 1% interest clause in them, even Ayushman Bharat and Swasth Sathi, you see the efficiency. Money is coming in 20 days. Yep. Okay, so that 1% interest clause works wonders. Number one.
Yeah.
Number two, our dear friends, let's take the BPA example. This business processing agency. There is a 2% service charge, and there is also some premium on efficiency, and they have a court case going against them for cutting the 2% without efficiency. But what I think has to be done is that they should be incentivized for better work, because I know for a fact the TPAs are not paid their right service. The value they bring, they're giving 2%, 3%. That's a joke. I think that's not right. But in some ways, if they can be incentivized for incentives, they can be some voting across hospitals for which is we think is the better TPA something. Although it's not easy to do, but that will help the TPAs maybe get more money and do things
more
correctly.
Efficiently.
Yeah, more efficiently. Of course, this being a very knowledge-intensive section, the staffing and training will continue to be a problem. And the biggest challenge for all organizations are how to keep the knowledge available to the team and the staff. Guys like me who have been around 22 years in this work, I will walk out and that's the end of all the gyan, unless until you call me for a webinar, right? So, we have not been able to sort of write the document, write the book, or make a course of this in various training institutes. I think that will hold a lot of our new graduates in great stead, and it will be a good way to further one's career. Thank you.
Thank you. Thank you, Dr. Bharadwaj and Dr. Colonel Pathak. You know, Saurabh and Arpit, both, it's open for you. The next thing which comes to my mind is that, you know, large hospitals have the human resources and the capital to, you know, put in the training, put in the staff, manage the staff attrition, bring in new people, quickly train them, get them to the work faster, you know, follow up, you could create a new department, outsource the work. But what about tier 2, tier 3 cities, smaller hospitals? What are the kind of challenges they face? Okay. Saurabh or Dr. Arpit, any one of you can take it. Go ahead, sir.
Okay. So first of all, I would like to actually support what Dr. Bharadwaj said about the interest clause. And again, I am stepping back and taking the viewpoint of beneficiary. So what is happening is a lot of hospitals, corporate hospitals, are stopping ECHS and CGHS payments, or even treating, not the payments. I take basically treating patient. Now, who is suffering? It's the beneficiary. So the entire system is
Patient.
built to, this entire system is built to support patient, but they are the suffering because of this. So that is the bigger aspect which needs to be looked into. Okay, so when we talk about tier 2 cities, there is only one problem, which is the biggest: availability of skilled manpower.
Yeah.
It becomes worse, be it any manpower, it becomes worse when you come to a tier 2 city, because people who are hardworking, people who have quality education, they all move out.
Wow. Yeah.
So first of all, just to get someone to a city like Lucknow, I sit out of Lucknow, which is practically a tier 2 city, it is very difficult to get quality manpower. The other thing which, uh, again, we are talking about training and not being able to codify what we know. Now, we all must admit, as healthcare professionals or hospital professionals, we are very poor at knowledge management. So we know some aspect, our colleagues know something, but nobody has codified. And have we incentivized people? So this is, see, I have worked across many industries, and when I was in McKinsey and GE, now in GE there is actually uh, your appraisals, yearly appraisals are linked to what you create on the knowledge portal.
Performance.
Do you actually go for a green belt project or a black belt project? Similarly, McKinsey, I used to actually publish 3, articles, and there is a knowledge portal. I need to, so whatever projects were done, what were the key learnings, a training module. So have we created some codification of the learning? That is a big question to be asked, because again, the way things are moving, I think there will be a lot of churn of healthcare resources, and to safeguard our processes, it's vital that we start codifying some of this information.
Codifying. Yeah.
Yeah. The second thing is to actually, because as Dr. Bharadwaj said, we have very specialized people sitting in TPA, but how often do we actually call them for a cup of tea? It's not that easy, but have we actually called them and asked, what are the 3 basic challenges you face from the documentation or the claims with respect to our hospital? Have we done that? I haven't done that, but that could be a good thing to actually call them, or even go to their offices uh, and just ask them, can you spare some time and at least tell us what are the mistakes we should not make?
That's a very important. Yeah.
The third thing is, we all, and I started the use of technology, but see, there is a lean concept, which is automation. There is something as automation, and there is an automation. We should not go for blind automation. We should go for automation, which is automation with some human intelligence. Now, why I'm saying this is, we talk about technology. Now there are 35, 40 odd TPAs on my panel. Half of them do not have their portals.
Yeah.
Even if they do have portals, it is so difficult to actually go to 35 various portals and fetch the data. Can we not create an integrated system? And again, it may be an utopian thought, but can we not create an integrated system where every claim or every TPA has to, register the process, and you have the ID and you can see what is the status? Because it is practically important. Tomorrow there will be like 50 TPAs on my panel, and I will have to depute 3 manpower. Again, there will be a question of training those manpower and everything. So that is a big question. Which more technology, are we solving the problem, or we are,
complicating the whole thing?
Yes.
Yeah. So it's either the devil or the Dead Sea kind of a situation. So, one of the key highlights which comes across most commonly among all your thoughts, whether it is yourself or Dr. Bharadwaj or Colonel Pathak or Dr. Arpit, maybe Dr. Arpit can take this further, is the aspect of communication, and mainly communication between the TPAs and the hospitals, and of course how the hospitals communicate what the insurance covers and what it doesn't cover to the patient, maybe the patient counseling part. So would you like to elaborate that a little bit, or add any other points, Dr. Arpit? We are almost nearing the end, so your comment, sir.
Yeah, so as far as the communication is concerned, so more or less there are certain terms and conditions of the policies that is actually a part of the approval letter with the TPS providing to the hospital. And if there is any doubt, the TPA guy of the hospital can anytime contact the call center of that particular TPA to make sure that he is clear what needs to be communicated to the patient. But yes, there are certain challenges which are there wherein the TPA also commits mistake, the hospital also commits mistake, and the TPA at times I can completely correlate, don't put a particular copay clause which is there in the policy. Again, the role of technology, some sort of system glitch, system error, the system doesn't tell, and eventually the hospital has to suffer at the later stage when it comes for claim settlement. At the time of claims, it shows that if there's a copay needs to be deducted, or a proportionate deduction needs to be deducted, a room rent needs to be deducted. But yeah, an effective communication is very important. I can say the larger TPAs which are there, they have a call center wherein the hospitals can call and communicate, and most of the information is provided in the approval letter which is provided. As far as the communication is concerned, I would like to highlight one point. As you rightly spoke about tier 2 and tier 3 cities. As a TPA, I can correlate that we have the proper communication with some of the top providers that we have in the country currently. So I can say proudly that 100 top providers which are there, they effectively communicate with us, not only for the queries that we raise, also for the outstandings that they have. But the problem is with tier 2 and tier 3 cities. As again, the role of training, they have very few manpower. In bigger hospitals, you have dedicated people who are trained and who is processing the TPA claims and all. But in a smaller hospital, the same guy is doing front office, the same guy is doing billing, some guy is doing. So that's wherein it's very difficult to train them, and their focus is somewhere else. So it's like that's the biggest task that we have. And we are not able to contact those hospitals. If there's an issue, if there's a bill which is pending or there's a shortfall being raised, we can't get in touch with the smaller providers. Especially there were claims which were, say, December 2019 claims, or say January 2020 claims, and we needed to talk to those hospitals because of the COVID scenario. Smaller hospitals were closed. Okay.
Yeah.
So there was nobody to even pick the call. So as a result, the aging of those cases, 3 months, 6 months, and subsequently these cases become non-payable. So and of course, as I rightly said, the communication is not that good from smaller hospitals. That's one of the reasons that the smaller hospitals are also bearing the brunt. Because see, I can understand a 5 lakh claim for a big hospital, can be considered as a bad debt for some of the big hospitals. But a smaller hospital which is only having 2 claims in a year of 5 lakh, and one of those goes into bad debt, it's like it's taking a huge hit on their P&L statement. So yeah, correct. So that's what.
Yeah, I mean, you brought in that important point. There is a large gap, and of course, we need to work towards building that gap. One of the key things is training. The other thing is about introducing the right kind of technology. We spoke about reconciliation, communication between different parties involved, including the auditors at the end of the tax season. At the end of the day, I guess I won't say any concluding statements. I leave it to every one panelist of over here. I think I would right now invite comments, closing comments as to what are the key 3 points which you think can help us solve this problem now that pandemic has opened many different chapters. What are the key top 3 things we need to look into?
Dr. Ashwath, just to add to that point, I would request all the panelists to keep their points really short. So if within 30 seconds, if you can answer this question, then we'll also take some questions from the audience, because we've we're seeing a lot of activity in the chat box here.
Thank you. Thank you. Go ahead, Dr. Bharadwaj.
Dr. Bharadwaj has raised his hand, so maybe we can start.
Yeah, but I got 30 seconds, so I'll keep it short. I think if you really want to set things right, I somehow feel that there is not enough lateral thinking done to reset the button. First big point, I have to say. Insurance is an endowment product. Every year, everybody renews. We can just change everything for the better, and in 1 year time. All policies are on one server, all processing happens on one software, and everybody pays per use. This will totally end all the issues which we are facing. It is highly doable, and the whole country will benefit from it. Thank you. 30 seconds over.
Thank you. Colonel Pathak, any last comment before we take up one or two questions?
What I personally feel is the hospital should follow ethical practices and raise ethical bills. BPA should clear it on time. Otherwise, what Dr. Saurabh had suggested, there should be some sort of a penalty or a interest which they should pay on delayed payment to the hospital. No outstanding claim beyond a period of maybe 10 to 15 days if everything is right. And lastly, basically it is familiarity, efficiency, and training that will help your faster payment and clearance of bills, will stall outstanding payments, and there won't be any delinquent claims. That's all. Thank you very much.
Fantastic. Mr. Gupta, your thoughts?
Yes, I think Dr. Bharadwaj and Colonel Pathak has already covered it, but in addition to this, I think the role of communication cannot be ignored. So enhance communication, and it is not between patients and hospital. It is also between the hospital to the payer, be it TPA or whosoever, and both ways communication. So, proactive communication, asking how things can be improved, what are some of the key things, and again, role of technology plays a vital role in this.
Brilliant. Thank you. Dr. Arpit, any last comments?
In continuation of what Dr. Saumitra said, I think transparency through strong technological integration, wherein the hospital, the TPA, and the insurance company, they exactly know the reason for delay in payment, whether it is a query being raised. So there should be no gray area, as in the hospital doesn't know why the payment is not coming. The TPA does not know why the insurance company is not, giving the payment to the hospital. So I mean, to the strong system which has, all the three stakeholders, and they can clearly see what exactly is the reason for the delay in payment, and of course they can follow with the concerned stakeholders then and there in the system.
Fantastic. We have slowly started working towards an integrated receivables management system. Of course, we have started taking baby steps. All your thoughts and all the learnings from this webinar will obviously pass it on to the engineering team to kind of brainstorm and look at how we can improvise the experience right from point A to point B, like the complete assembly line one of the panelists mentioned. Arnav, any comments?
Just a simple thing as hospital account details in a system.
Yeah,
it should not have a different account details as the insurer, or the hospital should not be sharing any other account detail to any other insurer. So it has to be a common. It's fine that the account details can be different for different TPAs or insurers, but it has to be right there, and that the system should pick the payment from that particular system, so that there's transparency that this is the reason this payment has gone through and not gone through. So that's what I feel. A lot of payments are not gone through because hospital account details are wrong in the system. Insurer has different, TP has different, hospital has shared something else. So all these things are there.
Yeah, it's a little complex, but one step at a time. Mr. Gupta and
just one
Saumitra have raised their hands. Yeah,
if you see the other side of the coin, sometimes and many of the occasions we don't know whether the payment is coming. It's coming for which claim. Because only as I know, so we also get confused. So that's the other side of the coin.
Yeah, so absolutely.
Of course, there has to be a transparency. If so, one of the cases wherein you receive payment, you don't know it belongs to which particular claim is one of those addendum cases where a case has been partially paid to the hospital and they have paid it separately in a different claim. So of course, it has to be associated with the main claim or the main premium. That's one of the
as
solutions.
I was saying, all the answers to all the queries exist within this panel, you know. So absolutely, and we can go on and on. There's something about lowering the deduction percentage. There's a query I just wanted to say. The hospitals should document a claim where the clinical side speaks clearly of the billing being done and the claims put in all the right papers. The real disconnect for deductions is clinicians Tokyo ja rahe hain or claims London ja rahe hain, and there is no connect. And if you take care of that, your deductions will be minimal. This much is enough to
bring the alignment.
Deductions.
Bring the alignment in terms of documentation. Arnav, any questions from the attendees? I have Srikanth here. Can you just read out the question, please?
Oh yeah, sorry, I was on mute before. Dr. Bharadwaj just answered one of the questions, but a question before that was raised by Mr. Bajaj regarding the period that one should consider before considering the write-off outstanding. So how long should that period be? Maybe we can have one opinion from the TPA side and one from the hospital side.
Yeah, so my point should be, so if any payment which is not being received within 3 months from the date of claim has to be reported to TPA, the person has to be communicated to, so that if the payment has not come, there's a reason the payment has not come. And I genuinely can tell you, a TPA, it's very difficult for a TPA to look at each and every single claim, although they look into that particular case and I find out the reason. But if the hospital can raise the issue and just follow up with the TPA, it is relatively easier because the focus is more on those particular, and we can help with whatever issue we are facing. So I feel 3 months is the time where we feel it is an outstanding, and we should start following with the TPA if you have not received the payment in 90 days. Again, there is no I would say a bang on answer to it, because every insurer has a different time period. Some of the insurers are saying, okay, you have to, as per the SLA, you have to submit the document within 7 days from the date of discharge, and the payment should be credited within 30 days, which I feel is rarely happening at this point. So it depends from insurer to insurer, but holistically it should be 90 days, not more than that.
Kind of raise a flag within the hospital system and then follow it up. All right, Dr. Bharadwaj, any comments on this?
No, I think write-off, both hospitals should pay money for any long-standing claim more than 6 months as initial fee for handling it, because what you really see in long outstandings, it's very clear that it is very complicated. Instead of working on one claim, I can work on 10 claims in that time, or 20 claims. So those will never be touched, and that's always the mute point, or where we get into all kind of discussions and altercations with the TPA. So some kind of flagging, some kind of discrediting happening from the TPA side if the claims are not right, and some kind of a basic fee of $1,000 or $2,000 to reopen the case in a justified way, maybe one way of looking at long-standing claims. All of us run into crores of these long-standing claims.
Yeah.
A write-off is a audit observation and an investor objection, although in our books they are basically written off in our final MIS. But these are very touchy issues, and the best way forward will be first clean up all the mess which we are left behind, and maybe post COVID-19 era, maybe a happier,
a reset button will trigger.
I think reset kar dena chahiye, for a better tomorrow.
Sir, एक साल से तो what I can say is, since the time COVID has come, I can understand hospitals are running out of cash flow, and the queries from the hospital and the follow-up have been very, very aggressive. So even the cases that they have not been following up, say 2 years back, they are saying कि वो 2015-16 के केस वो पे करो, वो नहीं होंगे पे. Insurer don't want to pay insurer. So even if we go back to him, they will say it's your mistake. Please deal with the hospitals. So that's our part.
Okay, so reset button is required. With that, I think we should all complete, and we have noted all the points, and we will brainstorm with the engineering team and come up with some solutions in the near future.
I have a
yeah. Go ahead, sir.
Just wanted to say about the outstanding claims. At least ECHS is much better, because no doubt there will be outstanding claims which have been there for 6 months, 1 year. Except that window closes, you cannot upload any documents. But if you take a waiver, the window is open for a duration of about for 24 hours, 48 hours. The permission is accorded. The hospital can account. Because we at our end realize that the hospitals have rendered services. Whoever fault it was, they are entitled for that payment, be it after 1 year, 2 years. They are entitled. Why should they suffer the loss?
Yeah. So policy changes are another important thing. Yeah, agreed. Vibha and Arnav, any closing comments? I think we have exceeded the time by about 6-7 minutes. We'll close the meeting with all the permission from the panelists.
Right, sir. So I'll just like to say thank you to all the panelists and to the members of the audience for such an enlightening discussion. And throughout the discussion, many important points were raised, and a lot of them will be incorporated into the blogs that we write and the work that we do. But our IRMS system, as Dr. Ashwath mentioned, has tried to simplify many of these processes, tried to increase the communication channels. So we hope that more and more hospitals adopt that. And going forward, just very grateful to the panelists and to the members of the audience, and hope to stay in touch with you. Thank you so much.
Thank you.
Thank you. All the best.
Thank you.
Thank you.
Thank you.
Thank you.
Jai Hind.
Thank you.
Jai Hind.
Jai Hind.
Jai Hind.